and a slight change in the program. Our first speaker would be Dr. Panjabi, who is currently a resident physician at Mass General Hospital right now. He's also the director and founder of an organization called, please bear with me, Tiyatien. Did I pronounce it? Tiyatien.
Tiyatien, yep, that's right.
You said it better. Thank you, Dr. Panjabi. An organization which is focused on providing equitable health care within the public sector of his native homeland, Liberia. Thank you.
You think it's a real movement when you have an infant in the back part of the yeah. Well, thanks for having me, and where did you go? You're so tired. Thank you so much for organizing this and to all the folks that were collaborating on this project. I'm from Liberia, although I don't look it, but I did grow up there and feel in many ways it was born there, but also gave me a birth of conscience, and it's just so exciting to see people rallying both around Liberia and also the broader movement to get focus on people affected by this pandemic. And thanks again for accommodating me. Because of that first line of the bio, which is very flattering, I do have to work 80 hours a week at the hospital. I have to, I'm the bottom of the pyramid over there, so I have to run back to the hospital. So I apologize to other speakers. We hope it didn't inconvenience you guys too much. I'd like to talk about, we had a few conversations a little bit earlier about this, about the promise of involving communities in the movement to both end AIDS and hopefully hit at the roots of the AIDS epidemic in the first place, being poverty and inequality and injustice. So this will all be the perspective of our work in Liberia. And this is a nice segue to what I was going to talk about. I think you did cover the history of Liberia, and so I'll skip over these slides, except that I think the war being such an important factor in the last 15 years, displacing over 1 million people and killing 250,000, and that has really driven Liberia. So I'll just jump straight to some of the images. This is really the violence of the relics of that violent disruption really spot every corner of the country, roads and clinics, and these are some of the rural areas in the southeast where we work. We're all really stripped bare, as you can see, and this is really just part of that swath of the country where and the reality of what people have to deal with. And believe it or not, this is a road that a logging company, built as a concession for taking forest part of Liberia. So, which you can see they invested a lot in. So, what has been the human cost of the problems in Liberia? I think Anne just really articulately did a great job of presenting some of the problems in HIV, and just broadly, under 5 mortality, so a quarter of children die before the age of 5, and maternal mortality, the mothers dying during labor or in pregnancy, is among the highest in the world. Liberians only expect to live 42 years. There are only 50 doctors left in the country to take care of over 3.5 million people. And mentioned a clinic in Monrovia that only has 1 doctor, and where we work, there's only 1 doctor as well, and this is true for so many parts of the country. 300,000 people to be served by 1 doctor, 1 hospital. And the majority of the structures have been destroyed before the war. But still, in this context, I think we always paint pictures of dooms from these types of settings, and I think what's important to realize, and hopefully this presentation focuses on stories of hope and real energy and resilience of United people. Despite all of these enormous odds, the Ministry of Health, the government of Liberia, and the communities there have made a bold objective to say that we're going to rebuild this country based on equity in health, justice in health, and we are going to be a model for other countries coming out of war. So I think it's really amazing to have that kind of a mission and mean it as they do. And so we were asked in that setting, our group Tiyatien Health, which is TH in short, means justice and health in English. We were invited to work with the ministry on an HIV project, which is called the HIV Equity Initiative. Before I get to the project, I'll tell you a little bit of the background about our group. We were founded by a group of refugee farmers and people with in this epidemic. And our sort of medium-term focus is really to prove that local institutions in Liberia can build world-class organizations that can take on this epidemic and hit also at the poverty that causes it. We employ community health workers. We have about 50 of them now, and we work out of a small district hospital. We help support that hospital, a regional health center that serves about 300,000 people in the southeastern part of the country. It's Wedru, for those of you that know Liberia. We are trying to focus on that region of the country because it's one of the most neglected parts of the country. In fact, it's the most neglected part of the country, and has been for a long time. We are working with the Global Fund and the Liberian government. And we launched, in response to the epidemic in Liberia, but also the healthcare crisis, a program, as I mentioned, called the HIV Equity Initiative, which sought to deliver comprehensive treatment in this district, and also to focus on prevention and getting people tested. Before we got started, this was in 2007, there wasn't a single person on antiretroviral drugs. 2007, this is years after the Global Fund had come into existence, after activists like some here were fighting for treatment to be accessible for all. Not a single person was on these drugs in any rural public hospital in the country. And the major argument against it was that, in fact, they had a policy that said only physicians can prescribe antiretroviral medicines, the medicines that save people with HIV from extend their life by years and even decades. They said only MDs can do it, and the reason we can't get any drugs out is because we don't have doctors anywhere. We have 50 for 3.5 million people. Most of those are in Monrovia, and even in Monrovia, we can't get everybody out on the drugs that we need to be. So we tried a different approach. We worked with the government, and again, trying to focus on community, being a community-based organization that was truly grassroots, but also working directly with clinical care. Worked to really do a few different things. But free services, first of all, because the poorest of the poor really can't access care. They're asked to pay even minimal fees for their health. We worked to train some mid-level health workers and so non-doctors, although there are some doctors involved, but we train non-doctors in the country to work on providing ART or antiretroviral treatment and HIV services in the context of a primary care clinic. So we focus not just on HIV, but to help reduce stigma, to help show that this is a chronic disease. We focus on things that we focus on here that people there, of course, have too: hypertension, high blood pressure, heart failure, depression, and substance abuse, which are also ranking problems. And the most important thing, the cornerstone of our work, was to employ community health workers. So these are people with the disease, people who are their neighbors, living in these rural communities, and we pay them and ask them to take on activities that doctors would be taking on or nurses would be taking on, but they can't because they aren't there. They provide not only delivery of medications to the home, but they also serve as a lifeline that will lead to a referral for the communities back to the hospital. And they provide, most importantly, something we like to call accompaniment, which is a term that basically signifies the idea that someone's going to stand with you in solidarity throughout the course of your life and with your community as well. So we, of course, trying to hit at the poverty issues, focus on food and training for agriculture and business. So just to give you a little area orientation, we're in the southeastern region. As Ann mentioned, it's only the size of Ohio, or sometimes I like to say Tennessee. But it takes 12 hours to get there from the capital because the roads are that bad. I saw a couple of pictures earlier. Most of the people we work with are farmers and hunters in the southeast. It's an incredibly beautiful place. And these are some pictures of our community health workers. As I mentioned, they are trained by ministry staff, government health staff, clinical staff, as well as our staff. We started, if you can look in the back here, there's some tiles. We actually started out of a war-torn hospital in a bathroom, what used to be a bathroom for 2 years ago. And our community health workers walk miles a day